So today I was going to talk about hyperacute head injury. It's kind of it's a term that's kind of been coined fairly recently, I guess, and the association with cardiogenic shock. Now, forgive me, for those of you that were present last month, there's going to be a little bit overlap from the cardiogenic perspective, and I had no intention today to talk to you about different types of traumatic brain injury and the anaesthetic management of that, because you're all experts in that already. So we're not going to be reviewing AAGBI guidance and European Brain Consortium stuff. This is more kind of theoretical look into the association between brain injured patients and cardiovascular instability. And then we're going to finish off by talking about the role of FFP and cryoprecipitate and early blood product administration in brain injured patients, and some of the recent trials that have been showing signal towards benefits, but by no means proven evidence of their role. I also want to talk a bit about diffuse axonal injury and how we as anaesthetists can probably have an impact on this. Again, it's more of a theoretical slant on that, but I think specifically from a pre-hospital perspective, there's a lot of merit in considering that. So just to start off with, I guess, thinking about types of head injury, we're all familiar with the classification systems based on GCS or the anatomy of injury itself. When we come to think about diffuse axonal injury, it's a little bit more difficult to kind of rationalise, because the radiographic diagnosis and detection of that pathology is quite difficult, and certainly the clinical presentation of a DAI is much worse than the imaging might suggest. I'm going to look at this a little bit more detail with a slide on actually what DAI is, how we classify it, and some of the implications from an anaesthetic perspective, specifically about reperfusion injury and how we can minimise the progression of the diffuse axonal injury itself by, careful control of oxygen and carbon dioxide parameters and ventilating these patients. We're going to spend a bit of time on this term hyperacute head injury, and I'll go into that in a bit more detail. There's lots of different terms used to describe this, but hopefully they'll be a bit clearer in a few moments. One thing I wanted just to touch on, and I guess this is more of a pre-hospital triage consideration, but there's a really good paper, I think it was back in 1980s, which retrospectively looked at loads of patients with intracranial hematomas and pathologies, and then went back and looked at their presenting kind of signs, if you will, and they were able to kind of risk stratify patients based on whether or not they had skull fractures or not. So when these patients arrive to ED, do they have a boggy head swelling? Because it's very difficult clinically to recognise, is there an actual fracture there? But if there's a big swelling, it's a bit boggy, it looks quite nasty, and you think, oh, there could be a fracture under that, then that kind of helps us think about, the risk that these patients might have from an intracranial pathology. And then obviously we're going to think about their GCS, but actually it doesn't take a lot. So if you're just disorientated with a boggy swelling, then actually you've got a 25% chance of having some form of intracranial pathology. Now, this paper never went into looking at the severity of that intracranial pathology and outcomes, so it's quite a superficial look at it, but it's certainly something that I use pre-hospitally quite a lot to assess patients and go, well, they're a bit confused, but they're starting to improve. The physiology's fine, so I don't necessarily need to do anything for them, with regard to a pre-hospital anaesthetic. But, we're equidistant from a TU and an MTC. They're kind of triggering on the trauma tool. What do I think their chances of having an intracranial pathology are? Well, actually, if it's a 1 in 4, why don't we go to Queen's or to Sheffield or to Coventry, go to the major trauma centre. And I think it's relevant, as an anaesthetist receiving these trauma patients in the ED, going to scan, just having an awareness of what the risk of them having something is, just to get theatres teed up and just to think about ITU, etc. Okay, so enough rambling about that. I want to talk a bit more about hyperacute head injury. There's lots of terms that have been used previously to kind of describe this phenomenon. You may all have been familiar with impact brain apnea. It's kind of it was described quite a lot. It's quite a historical diagnosis, and it kind of got forgotten for a while. And then John Hines, who did a lot of motorsports medicine, kind of brought it back into into the scientific field, I guess, to look into that terminology. And there's a few things that I want to specifically look at. So I'm not talking about an intracranial lesion itself. These are patients who've had a concussive force through their head, and it could be a deceleration injury, it could be an impact injury, but the concussion across their brain and across the brainstem has a massive influence on lots of aspects of the body. The first thing it can do is have a massive impact on people's ventilatory systems. So this is kind of thinking about whether or not there's a concussive force across the brainstem itself. It also impacts the cardiovascular system, and I think we under-recognise the association with brain injury and cardiogenic shock in that context. It also affects both your inflammatory cascade. It seems to be causing coagulation dysfunction and endotheliopathy. Now, when we think about blunt polytrauma patients, it's fairly well recognised that the trauma load itself impacts inflammation, coagulation, and endotheliopathy. But there's some recent evidence, which we'll go through shortly, which would also suggest that brain injury itself seems to be causing these pathological processes as well. And whether or not that's a shared pathway is yet to be established. So let's focus a little bit on the neuroventilatory stuff. So this is all really old data. I think this paper was in 1998, but there's stuff about impact brain apnea all the way back in the 80s. And there's lots of animal models out there. So this is a rat model. There was a concussive force, percussive force applied across the brain of the animal. And there's three different graphs here on the right, the A, B, and C. A is kind of a minor force, B a moderate, and C a major force, if you will. And what's really fascinating is you can see as soon as you've got the impact of that force, there's an apneic phase. And then there's a dysventilation phase, and then there's a return of normal ventilation. But in the animal model where there is no, where there's a high concussive force, actually ventilation never really reestablishes itself. And I think this is really important when we think about public health, education, training, and bystander information that's given by ambulance control about how to manage these patients. Because if we don't intervene early in patients who've got apnea or dysventilation pre-hospital, then actually the hypoxic brain injury that they'll sustain will in some cases be unsurvivable. You can also see there's a cardiovascular component to this this concussive force, and we'll cover that in a few moments. But you can see in every model, irrespective of the force, there is a surge in the arterial blood pressure itself, and I'll explain that in a bit more detail shortly. But thinking about why this happens, we think it's to do with this Botzinger complex, and this isn't something I'd ever really heard of before going to a few talks on this. It sits in the medulla of the brainstem. It's closely opposed to the respiratory centres and the cardiovascular centres. And there's some animal work where they, the top graph is where they've applied an inhibitory electrical potential across those Botzinger complexes in the brainstem of a rat, and you can see how it's just caused apnea. And then when they've turned that off, there's a compensatory increase in minute ventilation to offset that. Whereas if you and you have to inhibit both sides of the brainstem for that to occur. Whereas in the lower graph model, you can see a single stimulation of one side of the Botzinger complex in the medulla causes an increase in minute ventilation with a subsequent dysventilation or decrease in minute ventilation following that. Now, there's no human studies looking at whether or not this is the same process, but it certainly gives some food for thought of maybe this is part of the rationale behind the dysventilation we're seeing in patients with brain injury. There are two major gremlins with what we're trying to do at the moment. So when we think about the trauma and audit research networks, the TARN database, they've spent a lot of time and effort and money, cleaning up and data that's being recorded for our major trauma patients in hospital, which is great. But it might interest you to know that if a pre-hospital patient dies in the pre-hospital arena, they never make it onto the TARN database. So we've got this whole cohort of major trauma patients who are catastrophically injured, who don't survive to hospital, that just disappear into the ether. We've got no way of comparing clinical outcomes or looking into the role of enhanced care teams and pre-hospital services and interventions and hospital guidance and all this really important information that we need to investigate. And we've completely lost this group of patients. And there's work ongoing by the Air Ambulance Association to try and capture that information with a national database and repository and feed that into TARN. The other thing to think about, I guess, is that patient we just saw. So let's say he's had a concussive force across the brain, he's unconscious, he's initially apneic with some dysventilation, but the person who calls 999 calls a 999 operating centre that has access to the Good SAM teleconferencing facility. They get straight through to a critical care paramedic on a major trauma desk in the ambulance control. That critical care paramedic does a video conference with their mobile phone, which happens in some regions of the country. They turn the phone round, they look at the patient, and they can see that the patient is either completely apneic or has got some dysventilation, and they coach the bystander through doing a jaw thrust to open the airway. Now, what's really fascinating is that the apnea that you get in these patients isn't about an airway obstruction. It's not about the tongue falling back. There's no paradoxical diaphragmatic breathing. They're just totally apneic. But as soon as you open their airway, they breathe immediately. It stimulates the brainstem and they start breathing. And that patient might be a little bit obtunded when the crew arrives. They give some oxygen, they get into hospital, and their CT head scan's normal because there's no actual pathology to the brain. Whereas the same patient, the one that we've just seen, didn't have those interventions and now has an unsurvivable hypoxic brain injury. And the problem we have is that when we think about injury severity score and how patients make it onto the TARN database, you know, if a patient gets intubated pre-hospital, has a normal head scan, gets extubated either in ED or the next day, and then get discharged from hospital before 72 hours, they didn't exist from a major trauma perspective. Whereas that same patient who doesn't have those interventions suddenly dies on ITU with an unsurvivable brain injury. And you can see now why trying to pull out the role of enhanced care teams pre-hospital and how we're improving mortality or not, the case may be, is very difficult because we haven't got the quality of the data there to look into that. Good. So rescue ventilation, that's the key. You know, opening airways, giving rescue ventilation, getting these patients breathing at the scene of injury, and it needs to be a public health intervention because the ambulance service just can't get there soon enough. And the same is true for your HEMS teams as well. And this is where I think the role of pre-hospital anaesthesia has a massive impact because, you know, we've all been there when these patients have been intubated pre-hospital with a low GCS and the head scan's totally normal. And we all think, did they really need intubating? What was going on there? Well, actually, I reckon a significant proportion of that cohort are these patients who just needed optimal ventilatory care, just to maximise oxygenation, bring the CO2 into normal range, and just minimise any sequelae or morbidity from brain hypoxia secondary to this pathological process. Okay, so moving on to the association with the cardiovascular system. So again, a brainstem kind of concussive force seems to be associated with myocardial cell necrosis and actually petechial hemorrhages into the myocardium itself. So there's an association between brain injury and heart pathology. And again, this is pretty old data that we've known for quite a while that if you have a brain injury, you get a massive surge in systemic catecholamines. And there's loads of animal models out there to look at this cardiovascular kind of stress response. You know, adrenaline and noradrenaline's been released within seconds of there being a head injury. And the consequences of that are really systemic. So, you know, you get systemic release of these catecholamines, you get alpha mediated vasoconstriction, you get systolic blood pressures rising, increasing in afterload, pulmonary constriction, potentially neurogenic pulmonary edema. You've also got beta agonism, which is really intense, both from systemic catecholamines, but also the sympathetic nerve terminals on the heart itself, and it's causing myocardial cell necrosis on when we look at them histologically. And the combination of all these factors and the hypoxia and the hypercarbia that's happening because of the ventilatory response is causing the heart to fail even in our young patients. And you know, it's one of those bleeding mimics that I spoke about last month. thinking about patients with brain injury who've got failing cardiovascular systems, they might not necessarily need aggressive filling with blood products, and point of care ultrasounds and echocardiography might be part of the solution to recognising these patients. So just a little bit of evidence, not brilliant evidence, but just something to support some of the theories that I'm proposing here. So a study by Hassanin, it's a hostel-based study looking at brain injury, moderate and severe brain injury, and 50% of those patients they looked at had cardiovascular dysfunction, and what that dysfunction actually was varied quite significantly. It might be just ECG changes or troponin rise that wouldn't necessarily correlate with a shock state, but a proportion of them, not an insignificant proportion, got hypotension and abnormal echocardiograph findings. From a pre-hostel perspective, the Kent, Surrey, Sussex Air Ambulance group looked at a proportion of their RSI polytrauma patients who had brain injuries, and a significant proportion of them had some cardiovascular compromise pre-RSI. And the patients I'm referring to there are ones who on pan-CT didn't actually have any significant bleeding sources or massive trauma loads where you get lots of capillary and venous leaking that isn't really evident on CT. So the suggestion being that cardiovascular instability pre-RSI in the pre-hospital field was potentially brain injury related as well. So in terms of, I've spoken a bit about the kind of systemic effects of adrenaline and noradrenaline that's released in brain injury, but there's also a local effect. And what I mean by local is the sympathetic nerve terminals on the heart itself. And there's lots of histological work looking at the effects of dropping noradrenaline onto cardiac myocytes, and the longer it's on, the more profound the myocyte contraction. And patients who've died from significant brain injury but without any other major trauma pathology, on histology, you get this myocyte band necrosis on their cardiac histological slides. And we think this is part of the process of why they get this kind of stunned heart, this cardiogenic picture. But it's not just the heart that brain injury affects. And I alluded to this earlier when I was talking about kind of endotheliopathy, coagulopathy, inflammation. And there's a study by Batista et al., I've got the references later for if anybody's interested, that kind of showed a covariance with, the systemic catechlaamine levels through the body following brain injury in these kind of experimental models, and the effects of and the presence of biomarkers for these other pathological processes. What we don't know is what the mechanism behind these processes of endotheliopathy and coagulopathy actually are. Yes, they're present in brain injury. Are they driven by the same pathway that you see them in blunt polytrauma, so just major trauma patients? Is it exactly the same thing? Is it that the adrenaline and noradrenaline released in both states is causing all of this? I'm not really sure, but I think the point I'm trying to make from this slide is that, if someone's got a brain injury, it's way more complex than them just having low GCS and thinking about their neurological morbidity and mortality. We need to be, treating these isolated head injured patients just like we do with the blunt polytrauma patients, thinking about trauma-induced coagulopathy, early TEGs, managing their coagulopathy and resuscitation, point of care ultrasound and echo, and trying to recognise these bleeding mimics, the patients who are shocked because their heart's failing rather than that they're bleeding to death. Which brings me on to cardiogenic shock. So this is a slide that some of you will be familiar with that I've shown last time. So I'll just rattle through this just to kind of summarise my thoughts really. So why do blunt polytrauma patients become cardiogenically shocked? Well, hyperacute head injury is part of the process. And I used this term before, the tachysobria-like cardiomyopathy, that octopus pot where you get apical and mid-ventricular stunning and dyskinesis with the basal portion of the ventricle being spared. Well, actually in brain injury, you tend to see a reverse of that. The reason there's a reverse is because the sympathetic nerve terminals innervate the base of the heart, whereas the systemic catechlaamine receptors on the heart are more at the apex. So this cardiomyopathy that's being driven in brain injury is probably related more to local catechlaamine effects with that kind of logic. You get pump failure for other reasons, so bruise into the heart. So, you know, just yesterday I went to a chap who smashed into a steering wheel unrestrained, large sternal flail segment, very cardiovascularly compromised all the way to hospital. But, you know, his veins were up, his mucous membranes were still pink. There are lots of other signs and symptoms. Like he looks shocked, his capillary refill's poor, but I'm not convinced that he's bleeding to death. And, you know, a bit of judicious volume. I couldn't get an echo because his body habitus was too bad, but, you know, activated him as a code-red patient to Coventry. And, you know, his scan didn't really show any major bleeding sources. And I think that was just an example of somebody who's probably got brain injury with cardiogenic shock and maybe a bit of contusional injury to the heart itself. By the same mechanism, you can take out your valves, you can take out your coronary vessels with dissections. Trauma patients get cold, they get acidotic, that will affect their cardiac function. You can get adrenaline release just from major trauma loads itself, again, will damage the myocytes by the same mechanism. We've talked a bit, I've spoken previously about high, you know, cord lesions and brainstem lesions causing neurogenic shock. But one thing I think is probably worth considering is that patients who have a big tissue injury load, so degloving injuries to the legs, to the torso, lots of muscle bulk injury, lots of bony injuries, the cytokines that get released as part of that process, again, will damage the myocyte, but also cause kind of endotheliopathy and capillary leak. And this kind of surge response that we talk about in major trauma patients is probably driven by some of this. And what the right answer is to manage those patients, I don't know. I'd defer to my ITU colleagues on that, who are more experts in kind of managing these patients at the kind of, you know, 24, 48 hour mark. But I'm not sure that noradrenaline necessarily, or lots of vasopressors to maintain mean arterial pressures is the answer when they've also got multi-organ dysfunction secondary to poor end organ perfusion and capillary flow. And there's work ongoing with London at the moment on an RCT looking at regadenoson. So this is the REWIRE trial, where it's a randomized trial giving regadenoson, which is an adenosine 2 receptor agonist, in these big, sick, cardiovascularly unstable major trauma patients, to try and protect the heart from a lot of this pathological process that I've been referring to. And we'll have to wait and see if these novel treatments will work. I'll quickly go through this slide, and then I'll probably just talk very briefly on coagulopathy, because I'm running out of time. But I think end-tidal CO2 is really interesting, because how do we differentiate a shock patient who's got got cardiogenic failure versus hypovolemic failure? Well, the problem is that they probably have a mixture of both. But let's say, for argument's sake, we had one, you know, you could fall into one or two groups here. A hypovolemic patient will have a low end-tidal CO2. They'll have a low end-tidal CO2 either because they're increased their minute ventilation because they're so acidotic, and so they're blowing off their CO2, or they go into West Zone 1 kind of pulmonary physiology, where they drop their right ventricular cardiac output because their preload is so rubbish. They're not perfusing their alveolar capillaries very well, and they get VQ mismatch in their lungs. Patients with brain injury, just brain injury, who are shocked because of this kind of neurocardiac response, well, they either get a heart failure for the reasons I've discussed, and they get back pressure across the pulmonary capillary beds, and they match their VQ. That's assuming there's no lung injury itself from the trauma, of course. Or, you know, they've got a brain injury which has affected their ventilatory areas within the brain, and they're hypoventilating. And as a consequence, their end-tidal CO2 will be normal or high. So the take home, I guess, is if you've got a patient who looks really shocked, who's got, you know, polytrauma, and their CO2 is normal or high, just think this might not be bleeding, because you'd expect that to be low for those reasons. DII. So DII is, I think, is a little bit interesting because it's very difficult to diagnose, really, specifically clinically. You know, you get this kind of deceleration injuries, you get tearing of the axons at the interface between the grey and the white matter, and it results in these kind of petechial hemorrhages, which can be microscopic. So you can have a totally normal CT head scan as they come through the door. You can get, if you're seeing early poor grey-white differentiation, and it's a severe DAI. And the kind of classification of it is a three-stage approach. Either there's microscopic changes that you probably need an MRI to try and elucidate. You have lesions to your corpus callosum, you can see here on the left slide, on the slide A, or you've got focal lesions diffused throughout the brain, which you're seeing across both images. And often the clinical picture is worse than the imaging itself. But what I think is really interesting is that you can't do anything about the initial injury itself, so the traumatic side of this kind of pathway here. But there is a reperfusion injury that these patients get, which we think is driven by hypoxia and hypotension. So as anaesthetists or pre-hospital clinicians or whoever you are involved in treating these patients, addressing their hypoxia and the hypercarbia early, maintaining cerebral perfusion, the things that we do for all our brain injured patients, may have a positive impact on how much this DAI progresses. And it's why I'm a big advocate for patients who have got a brain injury and are obtunded and have got any issues with their ventilation itself pre-hospital to intubate and ventilate these patients early, because I think it's the right thing to do, provided you're confident that you can minimise the side effects of you doing that. So, not inducing hypoxia, so a safe anaesthetic technique, a patient with a decent looking airway who isn't massively cardiovascularly compromised unless you've got blood products to give them. I'll just talk about iTactic and then I'll call it a day there, Rob, because I'm running out of time, very conscious I'm approaching 12 o'clock. So iTactic, some of you will be aware of, I did a journal club on this a while back. It's a multi-center, big, massive multi-center RCT looking at, well, they call it VHA, so viscoelastic hemostatic assay. It's essentially TEG or rotum, right? Versus normal MHP guided resuscitation for bleeding trauma patients. Primary outcome was to compare those two groups with whether or not the patient was alive and free of massive transfusion at 24 hours. There were loads of secondary outcomes about organ failure, hospital stay, ICU length of stay, ventilator days, delayed mortality. Now, on face value, the primary outcome was that there was no difference between, the primary or the secondary outcomes between, patients who just have an MHP protocol or have a TEG guided resuscitation. And for the TEG non-believers, this was, oh, well, why are we doing it? It's you're wasting time, you're wasting money. But I think it's more than that. What they underestimated with this study was the incidence of trauma-induced coagulopathy. And those are the patients that were going to benefit from TEG guided resuscitation. And the reason the incidence of trauma-induced coagulopathy was so low in this study, which meant it was underpowered, was because the comparator group weren't getting any crystalloid. They were just getting blood and blood products. So on the one side, you could say, well, just do that because it works. But there is going to be a cohort of patients within the group who have MHP delivered resuscitation who will still get trauma-induced coagulopathy because they're so severely injured and their genetics are going to support them getting that anyway. And those are the ones that we have to identify early, and we can only identify them by doing TEG and rotum. The other thing it did show, though, was that there was a signal towards improved mortality in those patients with brain injury if you use TEG and rotum. And it's going to be really interesting to see the results of the Cryostat trial, because they've nearly finished recruiting now, because there's signal in lots of recent studies that actually early blood product administration, plasma pre-hospital or cryoprecipitate as part of the Cryostat trial, may have a positive impact on brain injury. And there's research groups at the moment looking to work up those studies. And I think that might change our practice potentially for the brain injured patients. So that's all I have to say. Quite a lot of references in this one, so I'll make sure that that's provided to Rob to distribute if anyone's interested.